Okay, I think we're ready to begin the presentation today. So welcome everyone to the latest event in our TSPN Talk series. This is the final event for the 2020-21 TSPN team, and we're very excited to have you all here with us. Today we'll be discussing knowledge translation and implementation, and we're very lucky to have Dr. Monika Kastner joining us today to lead this talk. I'd also like to thank the U of T SGS Sponsorship Fund for supporting this event. So I'd like to briefly go over some housekeeping items before we begin. Please note that this event is recorded and will be posted to YouTube at a later date. This event has live captioning, which can be accessed by using the Show Subtitle button. Should you like to submit a written question in the Q&A portion following Dr. Kastner's talk, you can do so by using the Q&A button. And we wish to acknowledge the history of the lands on which we are each living. Canada is home to many different Indigenous peoples. We ask that each of you take a moment to research, learn about, and reflect upon the Indigenous people whose lands you are currently on. TSPN resides in the Greater Toronto Area. We're located on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, and the Haudenosaunee, and the Wendat peoples. This territory is covered by the Upper Canada Treaties and is within the lands protected by the Dish with One Spoon Wampum Agreement. It is now home to many diverse First Nations, Inuit, and Métis peoples. And we would like to remind everyone that we have a strict no harassment policy at our events. So just a bit of a brief introduction to the TSPN. So TSPN aims to provide a platform for students, graduate and undergraduate, as well as postdoctoral researchers to learn more about and engage in science policy. TSPN is open to all disciplines and is not bound to one particular department at U of T and is inclusive of all areas of research. In addition, TSPN works with the community to advocate for evidence-based policy and to promote discussion on the science behind key policies. We do this through workshops, campaigns, and events. And if you're interested in learning more about our network, volunteer for future events, or join the exec team, send us an email, visit our website, or find us on social media. We have monthly meetings which are open to anyone interested in getting involved. This was the final event for the academic year, but please follow us to find out what will be happening throughout the summer and the next academic year. And TSPN is also now accepting nominations for our team next year. If you want to get involved, visit tspn.ca/get-involved to learn about the different roles. And now I'd like to introduce our speaker today, Dr. Monika Kastner. Monika is the research chair in knowledge translation and implementation at North York General Hospital and is associate professor at the U of T Institute of Health Policy, Management, and Evaluation. Monika's research interests and goals are to make a positive impact on the health of vulnerable populations with the use of innovative e-health technologies, and to advance the science and practice of knowledge translation and health services research. Monika is the recipient of the Canadian Institutes of Health Research New Investigator Award and the Early Researcher Award from the Ontario Ministry of Research, Innovation, and Science in recognition of her work on the Keep Well initiative, which is a unique mobile health application that empowers older adults and their providers to optimize multi-morbidity management. Thank you so much for joining us today to share your knowledge and insights about knowledge translation with us. I'll pass it over to you, and just to remind everyone that you can write your questions using the Q&A function.
Thank you so much for the introductions, Isabella, and thank you everyone for joining this talk this afternoon. I'm just going to share my screen. Okay, great. So I hope everyone can see my screen. So thanks again for joining this talk. The objectives of this presentation is really to introduce you and to define what knowledge translation is and why it's important. To introduce you to a wide spectrum of KT activities that can be considered to optimize knowledge uptake, and to discuss KT practice challenges and opportunities throughout the presentation, as well as some more specific ones. So what is really knowledge translation? So it's a relatively new term to describe a very old problem. And as you may imagine, and you may have heard of some of these different terms used for knowledge translation. There was work done by Anne McKibben back in 2010 where she identified over 100 synonyms, and I'm sure that has grown even more since then. But you may recognize some of these terms for knowledge translation. In the US, it's called dissemination and implementation. And even here in Canada, more recently, we're referring to knowledge translation as knowledge translation and implementation. And the CIHR, the Canadian Institutes of Health Research funding agency, has just recently started using the term knowledge mobilization. So KT is really the bridge between what we know and what we do. It's moving research results into practice to inform that optimized decision-making, both in the clinical as well as policy context. And it's really an active and deliberate process that involves all the steps between the creation of new knowledge and how we use or apply that knowledge. So as I mentioned, the CIHR has this definition for many years now. They consider it a dynamic and iterative process that includes the synthesis, dissemination, exchange, an ethically sound application of knowledge to improve the health of Canadians, and ultimately to provide more effective health services and products to strengthen the healthcare system. So as I mentioned, more recently, they've begun to think about knowledge translation more as an umbrella term, to think about it more as in terms of this wide range of activities that can be done to the production and use of research results. And so this includes a whole wide range of activities like knowledge synthesis, so systematic reviews, dissemination, transfer of knowledge, exchange of knowledge, and this co-creation or co-production of knowledge. And so this new definition is actually quite well in line with my philosophy of KT that I'd like to share with you in a second, that has to do with this looking at KT in terms of all of those different wide range of activities that you could do to optimize knowledge uptake. So just wanted to put KT research in the context of the type of research that you may be familiar with. So typically we do a lot of efficacy or observational kind of research to figure out what works. So we may do randomized trials, systematic reviews, cohort studies, and all of it really to determine what works to impact on patient outcomes. So let's take an example of what might be the efficacy of heart failure medications for decreasing mortality. So this may be a very typical question that you would think of when you're trying to figure out what works. It could be anything, whether it's medications, health services, programs, public health initiatives, whatever that innovation or program or intervention is. In knowledge translation research, what we're interested in is those determinants, so the barriers and facilitators of knowledge use. So if we take our example, the heart failure example, so we know that heart failure, there's available effective heart failure medications and they're prescribed, but often they're either not used, they may be overused, they may be underused. And so our job as KT scientists would be to study why and under what context this happens and who is involved to explain this problem. And just to clarify, when I say who, we often refer to knowledge users who are typically the people that are interested in the knowledge and they will actually use the knowledge. And so those could be a widely varying knowledge users. So they could be researchers, clinicians, they could be patients, families, caregivers. They can be policymakers, they can be anyone who will actually be interested in the knowledge or actually will use the knowledge. So other things that we do as KT scientists is that, we may also look at the implementation readiness of an intervention. So are organizations ready to receive that behavior change or whatever change that our innovation is there to produce? We also look at sustainability and scalability, and I'll explain those concepts in a moment. And then how do we disseminate research results into practice effectively? And this may be the area that you may be the most familiar with, which is dissemination or end of project or end of grant dissemination of knowledge. So the point that I really wanted to get across is that we need both to be able to have the most effective type of impact and sustainable and scalable impact. So why is KT important? So one of the biggest challenges that we face is that especially here in Canada, we produce too much discovery knowledge. It's a global problem, but we tend to focus on too many pilot projects that don't actually lead to implementation. And most of this knowledge doesn't have a deliberate effort to really think about how is this knowledge going to be taken up by different knowledge users. So we know that it's not enough to have just implementation, discovery trials. We need that implementation studies and trials, because these are the types of trials that can actually inform those decision-making that we need in the clinical and policy settings. So this all leads to this idea that the strong evidence or the best practices are not enough for us to have behavior change. So what we need is to systematically and deliberately implement the knowledge we produce into our healthcare systems. And that's where knowledge translation comes in. Another challenge another reason that why KT is so important is that much of the research produced is either wasted, reproduced when not needed, or implemented before being tested. So we have a huge amount of research waste. So there was a study done by Chalmers back in, I think the first one came out in 2010 and again in 2014, that over 85% of the research that we create across biomedical research, all kinds of different types of research, that 85% is wasted. That's crazy. So, and a big problem of this research waste is the lack of implementation efforts. So another challenge is that we don't always use the evidence to inform practice or policy decisions. So there's gaps that persist across different settings and decision-making groups. So we know that, one of the biggest gaps, obvious gaps that we see is that patients don't get the treatments of proven effectiveness, which is why we're seeing those practice gaps. Or more recently, a lot of work has been done around the implementation of low-value care, because a lot of we've come to recognize that patients are actually receiving care that's actually not needed, or they could even be potentially harmful. And even in terms of decision-making, up to 3/4 of patients and half of healthcare professionals don't actually get the information they need for decision-making. And same with policymakers. They don't consistently access or use evidence for decision-making. And even if we do use evidence, the problem is that it's either not implemented as needed, or they don't consider implementation quality or evaluate implementation. So we don't really learn about what are the challenges to implementation and did what we plan for actually work. Another big problem is that we don't always involve the target end users, those knowledge users that I just mentioned, in the creation of a lot of these innovations. And sustainability is often left out or too late at the end of the project rather than at the beginning. So one of the most staggering statistics that when I first came across this, I couldn't believe this, but on average, it takes about 17 years to translate evidence from discovery into practice. And only 14% of this of this work actually gets used in day-to-day practice. And knowledge translation can significantly shorten this period to about 3 years. So there's a huge potential and opportunity of using knowledge translation and using it as a science to be able to get that knowledge into practice. So how do we actually achieve knowledge translation? So we need to understand the context in which knowledge is being implemented. We need to understand what motivates people. So this is the psychology and the social aspects or the sociology of people and how they behave the way they do. And what are the opportunities for change and behavior change? And then what are the existing strengths that can be leveraged? We often leave this out. We always focus our efforts on identifying barriers and challenges, but we also need to identify the strengths because we want to be leveraging those strengths. And sometimes we don't even know what we're doing really well. And we need to do some work to really specifically figure that out. And of course, like how to collaborate effectively, there's a whole science that we call integrated KT, which I will describe in a second. And that really allows us to ensure that we involve all relevant knowledge users in research. Those are all different aspects that you would want to consider when you're doing a research project in any discipline or any field. So there's a really great model called, and some of you may have heard of this, it's called the Knowledge to Action model. It was developed by Dr. Ian Graham out of the University of Ottawa back in 2006. And it's a really fantastic process model that allows you to plan and helps you guide knowledge translation and implementation. It's built on a very solid evidentiary base. So they did knowledge synthesis and identified more than 30 planned action theories to inform this model. And it really is an iterative and dynamic approach to looking at how to deliberately cause change. And it emphasizes also the need to involve all relevant knowledge users in their entire process, which is what I described earlier as integrated KT. And in fact, Dr. Graham's group actually have created the IKT network, the Canadian IKT network. And they're actually studying the science behind how to make that integrated KT a practice as a way of enhancing knowledge translation. So I'm just going to describe this model just a little bit further, just to kind of show you how it works. So as you can see in the center of the model here is called the knowledge creation funnel is what it's called. And the idea is that through each stage of filtering that knowledge becomes more clear, the evidence becomes stronger, and it results in more useful knowledge for knowledge users. And it really emphasizes this idea that you have to tailor knowledge, that it needs to be increasingly distilled before it is ready to be used. So what are these different levels? So the first one is this, what we call first generation knowledge. So these would be examples of like this broad-based primary studies or just basic information. And so what we do then is, we synthesize this knowledge, and this is typically the base unit of all knowledge translation activities. So we tend to always look at the knowledge synthesis first before we do anything in knowledge translation. So by knowledge synthesis, there's a wide range of different types of knowledge syntheses. There's systematic reviews, which is probably the most common knowledge synthesis that I think most people have heard of. There's scoping reviews, which is a less focused question, a more broad-based when you're trying to map the literature. There are realist reviews. There's other qualitative synthesis reviews. There's a whole bunch of different kinds of reviews that allows you to synthesize that knowledge into more usable knowledge. So it's the idea that you want to look at the totality of the evidence when you're thinking about decision making rather than that primary base of knowledge. So then what ends up happening is that we, at the end of a knowledge synthesis, we will know in a given area or field what the knowledge gaps are, what might work, what could be the best intervention for different audience groups. So a whole bunch of different research questions that would lead you into creating those knowledge tools or products, which is the next level of filtering. So knowledge tools and products represent this further refining of the knowledge for decision making. And this is the actual product that can then lead to those decisions. So examples of knowledge tools and products are, there's tons of different ones, but probably the most common ones are, guidelines, any kind of guidelines, clinical practice guidelines or guidance documents, decision aids, clinical decision prediction rules, algorithms, policy briefs. So those are those products that are ready now to be deployed and used by knowledge users. So once we have created our knowledge, the next step is to really then think about these dynamic action steps that are on the periphery of this model, to then how do we actually get that knowledge into practice? And so there's a wide range of activities and steps that you can consider in any sequence, and you can initiate it in any action step, so you can see the arrows go both ways. So you don't necessarily have to start at a particular step. You can jump in when you already have your, you've selected your interventions, you're now monitoring it and evaluating it, you need to assess the barriers first. So wherever you are, whatever stage you are in your inquiry, you can use this model as a way of mapping things out. So the idea behind using this action model is that if you consider all of those different steps, you can actually deliberately cause change within the healthcare system and groups that you're targeting. So as I mentioned, it can be applied in many ways and in any discipline or field. It can help you structure a program of research or implementation of knowledge, to determine your target audience for the knowledge. And I've used this a lot in when I was doing my PhD. I've mapped out my entire project on this model and trying to figure out my target audience. You can anticipate potential barriers, problems. You can figure out the scope of your research. So which part of your research can you do for your master's and then your PhD and potentially a postdoc or whatever you want to do after that. So you can plan out the entire body of research using that model. You can track progress and develop timelines and inform a funding strategy, because oftentimes this planning will involve trying to figure out how you're going to fund this project. But ultimately, the goal here is to produce a body of knowledge that will be relevant to the people that will actually use this knowledge and apply this knowledge. So that is the goal of this. So I wanted to just also give you like it's my conceptualization of knowledge translation, because there's so many different facets to it that this is probably the best way of describing what we mean by knowledge translation. So there's this one area that we call KT practice. So, and then there's another area that we call KT science. So KT practice is really around developing and implementing a plan or a knowledge product, similar to what I just described using that model. So this could be an intervention, a program, a tool, whatever it is. And the idea is that you will make knowledge users aware of, and so that they can use the research results or knowledge of proven effectiveness. So for example, designing an implementation and scale-up strategy for an effective intervention that might be deployed across all of our Ontario health teams. Studying the overuse of medications in older adults and creating an intervention that will directly address this problem. Creating a pan-Canadian dissemination strategy to ensure the wide uptake of a new diabetes clinical practice guideline. So these are all examples of what we mean by KT practice. KT science, on the other hand, is really around studying the methods of knowledge uptake. So, things like improving the methods of knowledge synthesis. So I talked about, these different types of systematic reviews that we can use. So how do we improve the way that we actually conduct these reviews? So that would be an example of a KT science project. Another one would be creating a new model for sustaining effective innovations. So we know that sustainability and scalability are relatively understudied. So we may create a new model that helps us conceptualize that process a little bit better. So that's another example of the methods that we would, that KT science piece that we would do. Another example would be designing a tool that will help us assess the readiness for implementing something in an organization. So again, that tool, that's that methods piece that will allow us to do that. And then lastly, maybe creating a process to assess the sustainability of a program. So now I'm going to describe some common challenges that I've encountered, and I'm sure a lot of my colleagues and perhaps even you in whatever field or discipline that you work in terms of the challenges of practicing knowledge translation. So one of the biggest challenges that I've encountered, both as a trainee and more recently in my work and my teaching knowledge translation, is that we don't always use or consider the full spectrum of activities in KT and implementation science to optimize the uptake of knowledge. So what is really the scope of knowledge translation practice? So we recently developed this framework to sort of highlight all of the different kinds of KT activities that you can consider in knowledge translation. And so in the center of this model, you have 3 broad domains of KT activities that have been identified as important in the uptake of knowledge. So one of them is like the actual creation of knowledge products, which I described, so developing or adapting knowledge products. Dissemination, which is the sharing of knowledge, and then implementation, which is applying that knowledge. So I wanted to just skip over to dissemination because this is the type of activity that a lot of us associate with KT, because it involves that sharing of research results and the messages of those results with the appropriate knowledge users or audiences. And so this is really around all of those different end of project or end of grant kind of activities that we might do, like dissemination of your, so for example, publications, presentations, and those kinds of things. So I'm going to describe that in a little bit more detail in just one sec, but I just wanted to just very quickly say that spread, which is we often refer to as dissemination, is a little bit different than scale up. So spread is a process of adopting new knowledge, methods, and innovations developed in one setting into another setting or another context. And this often happens in a very unplanned and haphazard kind of way, versus scale up, which is a more deliberate and more systematic approach. So you might have heard the term scale and spread. And so often people use that synonymously, but it's not exactly the same. But what I wanted to just highlight in terms of the types of dissemination strategies that we often think of is this idea of diffusion, which we think of as letting it happen, these passive approaches of, publications and presentations. Then there's the helping it to happen. So this is more dissemination, more active approaches that are planned, more formalized, more tailored to the audience groups. And then the actual application of knowledge. So this is making it happen. And this is all about implementation. And these are the more intensive and deliberate strategies to move results into practice. And then so some of the methods around this, and I won't go through all of this table, I just wanted to really highlight, and then you can have it as a reference if you're interested to see what the differences are and the different levels of spread that you can consider. So here are some examples of each of them, their strengths as well as their weaknesses, because there's always a trade-off when you use one or the other. And the point is that it's not like you want to use one over the other, because we're going to, in different parts of the research projects, you may consider all of these are important, but you have to think of it more as the continuum of activities that you might consider in your dissemination and spread of that knowledge. So this is just, just highlighting that it's those two aspects that we typically consider as that end of grant or end of project activities. So let's now move on to these, what we call impact drivers, because they tend to be the determinants of knowledge translation and implementation science. And they should be considered across any or all of those three domains that I mentioned. So whether it's you're developing or adapting some sort of an innovation, whether you're disseminating knowledge, whether you're implementing knowledge, you should always consider integrated KT, sustainability, and scalability. So I'll walk you through each of those very briefly. So let's talk about integrated KT. So I mentioned this briefly at the beginning, and it's really just a way of doing research, this collaborative way of doing research, where everyone, all of those different knowledge users that you've identified as the people that need to know about this knowledge or you will use the knowledge, get together and they plan everything from the beginning to the end. They plan the research questions, they set the objectives, they select the methods that will be used, and right through to interpreting data as well as coming up with a knowledge dissemination plan. So knowledge users tend to have this unique expertise on the research topic. So let's say I was talking about the heart failure example earlier. So you might want to have a family physician, a specialist clinician. You might want to have some of the other healthcare professionals that are involved in heart failure care. And of course, patients and even family and caregivers that could be part of that knowledge user group. So there's huge value in integrated KT because it's been shown that collaboration between these researchers and these different knowledge user groups reveals those different perspectives, the expectations and the values, and it makes research more relevant. It creates trust and a shared vision that enable ongoing and effective partnerships. And there's many benefits to participating in the team. There's opportunities to reflect on individual skills. A lot of patient partners that we've had on our team have also said that they've enhanced their knowledge and skills in that particular area. They can learn about other pertinent research that's happening. And it's also a networking opportunity. You get new contacts with other researchers or knowledge users. So there's a lot of really great value in having that. And of course, this is something I've experienced in my work with older adult tools, is that you forge these long-lasting relationships that span multiple projects over time. And this is fantastic because it's this mutual benefit of learning together and coming up with new ideas and how to actually approach answering these research questions as the healthcare challenges that we are faced with. And so what happens during integrated KT meetings? A lot of people ask me this question, and it kind of depends on the research, but the way I like to think of it, and I think Anna Gagliardi, I really like this representation of how she thought about it, is really around the early, the mid, and the end of a project, because different things happen during that continuum. So it's really helpful to think about all of these different things that you might want to accomplish with your integrated KT team early on when you first start the project, establishing team roles and responsibilities, setting timelines, research questions, all of this stuff around planning and everything else. And in the midway of the project, then it's all about monitoring and are we, how are we progressing in our project? And are we, are there any, challenges and barriers and obstacles that we have come across that we need to discuss as a team that we can come up with and identify? And of course, at the end of the project, all of the different things around interpreting findings. I just realized the time, so I'm going to maybe speed it up a little bit so that there's enough time for questions. So we know that the active engagement of all these knowledge users as partners is a strong predictor of impact. And it's that whatever you produce will be more relevant, useful, and used by your audiences. And there's a greater potential for long-term success and to sustain the patient outcomes and those key stakeholder relationships. What we still struggle with, though, is that we don't know how we should do this effectively, how the collaboration process. So even assembling the team, but how do we maintain that collaboration? And the other trade-off is that it does take a considerable amount of time to do this well. And even in cases where you've got nationally funded IKT research and knowledge user engagement, it can be tokenistic. So we have to be very careful of that we have the representative people around the table, and they have a forum to actually say what they need to say to inform the research. And here's some typical KT challenges. And again, I won't go into enough detail here because I want to make sure I get through it. I also provided this tool that we've created that you can consider in planning for integrated KT. Then I wanted to just briefly touch upon sustainability, which is really a key implementation outcome in implementation. And it's really the degree to which an innovation continues to be used after adoption. And there's other ways of defining it, but ultimately I think the most important thing with sustainability, we know something is sustained when an innovation becomes part of routine care. And that's when we know that we've done our job with sustainability. So again, back to the research waste, poor implementation goes hand in hand with the failure to consider sustainability of innovations. This is another source of that waste, because we know that up to 40% of all new programs don't last beyond the first 2 years after initial funding. And it's the least applied of KT activities that I have showed you in that model. So we know that implementation is not enough, that we need that sustained delivery to be able to achieve those public health impacts that we haven't yet been able to achieve. So, another really important consideration in sustainability is that it needs to be considered and planned for early. So during the time that you assess your implementation barriers is when it should be done. And then again, it should be assessed after the evaluation of an innovation to identify the factors that influence sustained knowledge use. So scale up very briefly is the ability of a health intervention that to be shown to be effective on a small scale to now be expanded under real world conditions with a greater proportion of the eligible population while retaining that effectiveness. Again, this is just like with sustainability, it's a relatively neglected part of implementation. And the way we do scalability is the best approach is to plan for it, just like with sustainability. And it requires adequate human capacity. It needs support from financial, organizational governance, as well as regulatory structures. And it requires adaptation of the innovation or program. So how do we adapt innovation? So again, it's identifying those core elements of an innovation while retaining its effectiveness and relevance, and adapting the remainder of the elements to fit with the doctor context. So evaluation is the last piece of this model, and the way that it's structured in this model conveys the idea that evaluation applies to all domains and all impact drivers. So we should be doing evaluation on everything. So, the second challenge that I will again very briefly go over is this selection of KT and implementation science theories, models, and frameworks. And so we know that it's very important to enhance our quality, to use them as tools, to understand the mechanisms of change, to support the successful spread and scale of sustainability, to do evaluation. But it's really difficult to do because there's hundreds of theories, models, and frameworks that exist, and we don't always use them. And if we use them, they're not used appropriately, and we don't justify why we use the ones that we use. And there's little consensus on to which is the most important. And again, another driver of this confusion is the inconsistent language and syntax across all of these theories, models, and frameworks. So again, I won't go into any details, but this is a cheat sheet that I've used often to explain the differences between theories, models, and frameworks, the key features of each, the ones that are relevant to KT, their differences in relationships, and some examples. And more recently, there's, I'm just going to skip over to this slide here, which has been adapted from work done by Nielsen in 2015 that helps you kind of think through how to select theories, models, and framework. And it's really around, is your interest or purpose to describe a process or knowledge uptake? Is it to understand what influences implementation outcomes, or is it to evaluate implementation? So this is a really great algorithm that you could choose when confronted with that kind of challenge of selecting models and theories. And then the third challenge that, the last challenge that I wanted to very briefly mention is de-implementation. And it's not the same as implementation. So de-implementation is reducing or stopping the use or delivery of services or practices that are ineffective, unproven, harmful, overused, or inappropriate. And there's many similarities with implementation. So we, just as with implementation, we need to consider context, intervention, patient, health professional, and organizational factors in the implementation. But where lies the differences in their outcomes, the processes of the determinants, the drivers of change, and the complexity around the implementation. So again, I won't get into too much detail around the differences, but this slide shows some of the drivers of low value care and the differences, what you can consider for both versus what are some of the unique aspects when it comes to de-implementation. And of course, I think one of the most important and neglected aspects that really has shed some light on the health disparities, especially from the pandemic, is that we need to really be sensitive to the reactions of different stakeholders and to consider those health disparities and cultural relevance when we think about the implementation, just like we do for implementation. So I just wanted to end the presentation just by summarizing the power of KT. We need to practice KT using the whole spectrum of KT activities to maximize the potential for our impact. The KT theories, models, and frameworks that we have in knowledge translation and implementation should be considered as tools to help you plan, predict, guide all of the processes of your KT activities, whether it's dissemination, implementation, sustainability, scalability, or integrated KT. And just to think about de-implementation and implementation as having lots of overlap and similarities, but there are some really important differences that need to be considered when decreasing or removing that low value care. So I apologize for rushing through that last bit, but I'm happy to make my slides available to get more details. And I'm happy to take any questions that you might have.
Thank you so much, Dr. Kastner. That was really a really wonderful talk. That's such an awesome overview of this whole kind of field. I certainly learned a lot. So feel free, everyone, to put your questions in the Q&A, and I'll be taking those and asking Dr. Kastner. I'll just start with one of my own questions. So I was wondering what specifically do you think it is about the healthcare field that kind of like prompted this whole concept of knowledge translation to exist? And do you think all of these models and frameworks and everything can be applied to other fields as well?
Yeah, so those are really excellent questions. So I think our biggest drivers of some of the tools and the way we look at KT has been driven by the fact that we still have practice gaps. You know, we still have, you know, patients are not receiving care. The knowledge that we produce is not getting into the hands of those that need it. So, you know, we produce, you know, this is where that whole research waste comes in. So it's not just about research waste, the fact that we produce so much discovery knowledge, but the way we see it is the practice gaps. But then we also see it in terms of the volume of research that knowledge that gets produced, but it's not actually translated into practice. So I think that's where that's where it all comes from. And I think it's like that with any field where you have evidence-based information or best practices, whether it's architecture, or psychology, or chemistry, or health. But if that knowledge is not being translated well to those who need it, then you're not going to have the best practice. So it's kind of like that idea that could be thought about across the different fields. In terms of those KT theories, models, and frameworks, they can absolutely be used for other fields. I think the idea is that you've got context, you've got behaviors and motivation of people. So that could be in anything. And so the theories, models, and frameworks are really there to help you understand your context, to help you understand why people do what they do. And it also helps you to figure out how to create strategies that will then overcome those challenges or fill those gaps, and also the tools to help you evaluate and monitor and see. And then we use very typical rigorous methodological strategies, like different kinds of trials and qualitative studies, mixed method studies, like knowledge synthesis. So we use traditional techniques, proven rigorous techniques, to be able to actually monitor and evaluate and create those solutions to those gaps.
Thank you. Another question I had is who should be kind of responsible for ensuring that or overseeing knowledge translation? Should it be the researchers, scientists, the policymakers, the industries or organizations involved, or really a combined effort? Who should be, I guess, responsible for driving that process?
That's a really good question. I would say it's a little bit of both. So I think that definitely having, when I talked about the integrated knowledge translation, I think having a team that's there from the beginning to end. I mean, of course, there's lots of challenges around retaining people, but if you have a core team that's there from the beginning to end with the right voices around the table, that in itself will ensure that proper knowledge translation. However, there's different ways that you can optimize and enhance knowledge translation. You can have knowledge brokers, what we call knowledge brokers. So there's people that are individuals that actually can help support that translation of knowledge, or talk, encourage that communication between the different knowledge users. It depends on the project and the type of activity and the type of research you do, like biomedical research versus health services research. That's a huge difference between how you would do one versus the other. So I think having those kinds of support, someone who facilitates that, can also be very helpful in that process.
Thanks. Okay, so we have a question here. Thank you so much for this really interesting and eye-opening talk. And Muli is wondering how the conclusion was made that 80% of research goes wasted and not translated. That's the first question. There's another one in there too.
Yeah, so I encourage you to read that paper. I have the slides. I've got the references there, and I'm happy to share my slides. I think they did a lot of work, a lot of the the databases that capture research across a broad spectrum of research. So it wasn't just health services research, it was a large, it was a very broad-based investigation. And, the implementation piece is really around, is the things that have been created, are they actually being used? Is there evidence to support that is actually, it exists and people are using it and patients are benefiting from it? But I encourage you to read those papers. There's a series of papers around that have come out since 2010, I believe, around that. And I think it was published in The Lancet.
Okay, and the second, go ahead.
Yes. So yes, my answer to that is yes. There's a ton of examples, but that is to say, it's a fairly new science. So there's a lot, as I mentioned in my slides, there's a lot that we still don't know. We do face a lot of challenges with keeping a team together from beginning to end. And again, it depends on the project. Some projects that are, short-term projects, like 1 to 2 year projects, are obviously more like a lot easier to keep together and to have that sort of true engagement. Whereas larger projects like one of my projects that has been going on for over 5 years, and of course, we've had some, we've had people that have left the team. We've got new people that have joined the team, but the core team is still there. And we're still constantly learning about the best ways of keeping them engaged. And I also wanted to mention that it's not always appropriate to have an integrated KT team to the extent that you have, 25 different expertise around the table. So it's really important to first figure out what is the need for that project? Is there a need to have, you might only have 2 or 3 people or experts around the table, and that's probably sufficient for that project. So I'm not saying that you need to go out there and collect every single person that will be affected by the project. It's just really to make sure, especially patient engagement is really big, especially in health services research.
Great. Okay, we have a question in the Q&A here. It seems like in my field, the standard way researchers try to disseminate their findings more broadly is to publish a paper and promote the paper via press releases, media coverage, social media. Does media promotion mean anything to knowledge translation, or does it simply add some awareness?
Yeah, that's a great question. So social media, it falls into that, what I would call, I don't know if you remember, there was, the diffusion, which is just letting out, that's publications. So social media would fall into the next bucket, which is the dissemination. So this is a little bit more tailored, because when you send out a social media message, it's typically for a particular audience. So you could tailor that message a bit more, that has a bit more success than just to let it out there and then the onus is on a person to happen to see it or hear about it. So social media is more of a push strategy where you're actually tailoring that message a little bit more to a particular audience. So definitely there's many different strategies that sort of fall in that spectrum of, diffusion, dissemination, and implementation.
Okay, thank you. So another question I had is, are knowledge translation efforts mostly carried out at kind of like a national level or a more local level? Is there any examples of even like international efforts of this? Sort of what scale are these efforts happening at?
That's a really good question. So it's basically, you could do all of the above, but it's what will distinguish between whether you do more local versus provincial versus national versus international is several factors. The most important thing that should drive that is, where in that research program are you at? Are you at the foundational knowledge creation level? Or are you at the point where you've just tested the intervention with 2,000 people and you did a randomized controlled trial, and now you have definitive answers to your questions? So whatever the innovation is has to be proven to be effective. So that should drive, you're not going to go to extraordinary lengths to get the message out if something that you've created didn't exactly do what it was supposed to do. So that's also driven by the efficacy of whatever it is that you created, but it also has to do with the scope of the project. So when you do knowledge synthesis, that's something that, the knowledge that you create, the closest it is to informing decision-making, the more widely that you can spread it. So for like knowledge, the knowledge creation funnel that I described, the closer you get to those knowledge products, the more efforts that you can put into and should put into disseminating that knowledge. So it kind of is driven by all of those different things.
Awesome, thank you. Okay, it looks like we're just about at the end of our time here. So I'd just like to say thank you again, Dr. Kastner, for your amazing talk. Very, very eye-opening. And thank you so much for everyone for attending. And I just also like to thank the SGS Sponsorship Fund for funding this event. Thank you so much, everyone.
Thanks so much for the opportunity. Take care.
Bye.
Bye.